Welcome to the Early Pregnancy Ultrasound module for the WAX Ultrasound Learning System. I'm Dr. Casey Parker. So the goals of bedside ultrasound in the first trimester of pregnancy are pretty simple, and the most important goal is to be able to diagnose an intrauterine pregnancy. If you can successfully do this, then most of the problems then go away. Performing an early dating scan can also be very useful if you are able to identify an intrauterine pregnancy, although it's not necessarily required. And last of all, really critical point is to be able to diagnose what we call a pregnancy of unknown location, because this is a very important diagnosis, and this is one that needs careful and structured follow-up. Before we actually do ultrasounds in early pregnancy, we do need to do some pre-ultrasound counselling. This is a very difficult time for a woman and her family, and this is going to put a lot of weight on your ultrasound. No matter what you say, you need to make it very clear what the possible outcomes can be. And it's good to explore exactly how the woman and her family are feeling about the current pregnancy, what their beliefs are, and don't make assumptions about the situation. It's very important to establish all of this prior to doing a scan because it changes a lot of the thought processes. It's also useful to have a support person present if that's appropriate throughout the examination. Now, before I start, I usually try and outline that there's a couple of possible results of a bedside ultrasound in the emergency department for a woman presenting with symptoms such as bleeding or pain in early pregnancy. Now, number one, we may see a normal intrauterine pregnancy. Number two, we may see a miscarriage or possibly what used to be called a blighted ovum, which is now called an embryonic pregnancy. And the third is that it may be an inconclusive study. This is very common in very early pregnancy, although a possible ectopic or a threatened miscarriage can look exactly the same. It is also important to tell the woman that the transvaginal ultrasound is the gold standard for diagnosis in early pregnancy, and therefore if we do have an inconclusive scan, transabdominal scan that is, then that will require an MRT scan done, which may include transvaginal scanning as is appropriate for the clinical situation. So here's a very rough algorithm about how we go about imaging women in early pregnancy. The most important question is there previously been a documented intrauterine pregnancy? Because if there has been, then that makes an ectopic pregnancy very, very unlikely, and we can perform the scan. And the three possibilities that we may have is a normal IUP. It may be inconclusive if your scan's not as good as the previous scan, or we may actually see a miscarriage in progress, and we'll talk about the criteria for miscarriage at that point. If there is no previously documented IUP, this is really the most important part of doing an ultrasound. As said before, you may see a confirmed intrauterine pregnancy, which is great. We can then go on and date that and look at viability and get a subsequent scan when it's required. If we can confirm a miscarriage, and we'll talk about the criteria once again, then we have a follow-up plan for that, usually through the EPAS clinic. However, the most important group, the ones that we don't want to miss, is the pregnancy of unknown location. So if you have a woman who's pregnant and you cannot identify a pregnancy, then you need to be consulting the gynecology team. This is where the ectopics lurk, and you need to be aware of that. So a little bit about testing quantitative beta-HCG. We do need to do this if a woman has pregnancy and has a symptom such as bleeding or pain, and it is useful as a serial test to guide these inconclusive and the pregnancy of unknown location scenarios. However, the old-fashioned discriminatory zone is a bit of a myth. There's a very wide range of beta-HCG levels that don't really correlate particularly well with the ultrasound appearance. Therefore, if you've got a clear diagnosis on ultrasound, this will almost always trump the beta-HCG level, no matter what it happens to be. And we still send them though because they can be very useful as a subsequent follow-up, and also they can guide around the treatment of ectopics if you do actually make that diagnosis. Now, if you learn nothing else from this talk about how to do an ultrasound, this is the home base. This is the image that you need to be acquiring in order to say that this is an intrauterine pregnancy. So we call this the Nike tick or the reverse tick. if you get the uterus lined up in longitudinal axis with a nice full bladder at the front, you want to be able to see the vaginal stripe, which is usually a bright white line just posterior to the bladder coming down into the cervix, and then that reflects up into the endometrial stripe. And if you're seeing a pregnancy that's attached to that continuous line, then you can say that this is in fact an intrauterine pregnancy. In order to call it a pregnancy, you have to see a gestational sac, and you must see at least a yolk sac within the gestational sac. So you need a big sac that's the gestational sac, and then a smaller sac, which is the yolk sac within it. Once you've met all of those criteria, you can tick, this is an intrauterine pregnancy, and manage it as appropriate. Now, a little bit about bladders in pregnancy scanning. It is really important to have women fill their bladders before you attempt the scan, because it can be quite problematic if you get an inconclusive scan, and if that's the result of an unfull bladder, then you've just wasted a bit of your time, and you've probably increased the nervousness of the woman, because it means yet another test which hasn't been able to answer the question. So it's useful to try and fill bladders beforehand and have a look and see if you can get a really good look at that true vaginal cervix and endometrial stripe, so that you can say this is an intrauterine pregnancy. If you don't have a full bladder, this is the picture you tend to get, which is a lot of bowel gas. You may catch a glimpse or two of the endometrium or the cervix, but you won't be able to say for clear that this is definitely an IUP, and that can be really problematic. So it's worth your time just to fill the bladder before you have a look. Sometimes a really, really full bladder can be problematic as well. It can push the uterus further away and make it much deeper, so the resolution's not as good. And with women with retroverted or axial uteruses, this can be a problem as well. And to be honest, this is reasonably common in practice, and you can try emptying the bladder a little bit, but this is where transvaginal scan comes into its own. It makes it much easier to see what's going on. So this is likely to end up with an inconclusive scan, particularly very early on in the pregnancy. This is the worksheet which we're going to be using, that's written by Dr. James Rippey, and it's attached to the ultrasound machine so that you don't have to remember all these numbers and dates, because it can be a little bit overwhelming. But essentially you can correlate what you're seeing on the screen with what's on the card and make a bit of a guess as to where exactly this pregnancy is, if it happens to be in the right location, and what gestation it may be. Also shows the common ectopics which we see as well, so you'll be able to hopefully recognize those. Now, you don't need to remember all these dates and weeks and features, but what you do need to recognize that before about 5 to 6 weeks, it can be really difficult and common to have an inconclusive outcome, just because everything's so small, difficult to define, and it's better to call it an inconclusive scan than to have a guess as to what you're seeing, particularly when it's only 2 or 3 pixels on the screen that you may be looking at. Once you get past sort of 6.5, 7 weeks, things become much easier to see, particularly with a nice full bladder, and down around 8, 9 weeks we can usually be pretty sure about what we're seeing and get a good measure of everything and say that this is an IUP. So let's have a look at how these different pregnancies appear at different gestations. So on this is a transvaginal scan actually that you're seeing, but on a transabdominal scan with a thin woman or with a full bladder, you should be able to see at 5 weeks a gestational sac. And at this stage, it's likely that you won't be able to see a yolk sac within the gestational sac, depending on the size of everything. And so you can't call this an intrauterine pregnancy at this point until you've seen a yolk sac. However, this looks like a gestational sac. It's nice and round. There's a lovely decidual reaction around it, and it just looks like one to me. So you'll get used to this after you look at lots of them over the years. But if you can see these different layers and a nice round, robust looking sac, that probably is what it is. However, there's this thing called a pseudosac, which is essentially a collection of blood within the endometrium with a bit of a blood fluid level in it, which can look very much like a gestational sac. And it's a trap for young players, and this is why we make it absolutely clear that you need to see a yolk sac within a sac before you say that this is a true intrauterine pregnancy. So pseudosacs tend to be a bit irregular, a bit sharp, a bit collapsed sometimes. They contain some debris, but they still may have a decidual reaction because they often occur in women that are pregnant, but the pregnancy is not in the correct location, or you've got the timing completely wrong. So here's a few examples of pseudosacs. You can see they look a little bit collapsed. They sort of are right in the middle of the endometrial cavity, which is not typical of a normal pregnancy. Pregnancies tend to be a little bit off axis, not right in the middle of the endometrial cavity, and often don't have that nice thick gestational reaction around it. But it can be very common to fall into the trap of calling this an intrauterine gestational sac. So here we are, 5.5 weeks. By this stage, we should be able to see a yolk sac. So we've got a nice thick, round gestational sac, and within it we've got a thin-walled yolk sac. So once you see this, you can say this is an intrauterine pregnancy. Prior to this point, you can only have a guess that this may be a true pregnancy, but you can't say for sure until you've seen a yolk sac within the pregnancy. And of course, that sac has to be in the endometrium, which is continuous with the vaginal stripe. So you can say this is all lined up within the vaginal endometrial cavity. At 6 weeks, we see a thing called the diamond ring sign. So we can still see that yolk sac, but now sitting on top of it, there's a fetal pole, which is really just a blip. You can't really say too much about it, apart from that it's there. And usually at this stage, it's about the size of a grain of rice, and not typical to be able to see a heartbeat at this stage. Although with a good transvaginal scan, you may pick that up. 6.5 weeks, the crown rump length is 5 millimeters. It's about the size of a coffee bean. It's still difficult to say which is the head and which is the tail, but sometimes you can see a little heartbeat flickering away on the screen, and that may be very slow at this point. This may be sort of less than 100, which seems a bit alarming but doesn't really mean anything, so don't worry about that. And remember that this fetus is going to grow by about 1 millimeter per day. So if you come back and do another scan in a couple of days, around the 7-week mark, you should be able to see something that looks much more like a fetus. And at this point, we've cracked through to 9 millimeters. And once a crown rump length is more than 7 millimeters, you should be able to identify a fetal heartbeat. This is one of the criteria for miscarriage. If the heart rate is going along fast, then you'll definitely be able to see it. And usually by this point, we can see which is the head end. 8 weeks, it's starting to look much more like a baby. So we're looking tiny teddy size now, 16 millimeters, and you may see some little limb buds poking off. Definitely should be able to see a heart. And then obviously as things go along, things get bigger. It continues about 1 millimeter a day throughout the first trimester, and you start seeing components within the brain. So the little cysts within the brain is the rhombencephalon, and you'll start to see a fast heart rate. And you also start to see movement at this point as well. So talk a little bit about fetal viability. So viability in sonography term means that we've seen a fetal heart rate. So we've put a Doppler on, or we've just saved a video loop of this fetus, which is documenting that there is a heart rate. If you've also seen some fetal movement or some respiratory movement, then that's also evidence of viability. Although traditionally we just take a clip of the heart rate, and traditionally with M mode, and we push freeze, and most of the machines have a way of measuring the heart rate. On this machine, we've measured 2 cycles of the heartbeat, and that machine averages it out to give us a heart rate of 172 there, which is normal. So we talked a bit about pregnancy failure rules. So when can we call this a miscarriage? So as I said before, the gestational sac and the crown rump grow by about 1 millimeter per day, and the mean sac diameter is of course a measurement measuring all 3 dimensions of the sac. So you have to measure the sac in trans long and as well in width. So you need to measure it in 2 different planes in order to do that. And once that mean sac diameter is greater than 25 millimeters, you should be able to see a fetal pole within it. If not, then it becomes what we call an anembryonic pregnancy. Now, the other hard rule that we use for diagnosing a miscarriage occurs at about 6.5 weeks. As I mentioned before, once the crown rump length is greater than 7 millimeters, you should be able to see a heartbeat within that. So if you're seeing a fetus that's longer than 7 millimeters with no heartbeat, then that's suggestive of a miscarriage. And depending on how you feel, whether you feel confident or you just want to get a formal scan to confirm this, that is one of the rules for a pregnancy failure. Other things that you may see that in women, particularly who are presenting with sort of painless bleeding in early pregnancy, you may see this, which is a subchorionic hemorrhage, which is very common in early pregnancy and is often attributed as the cause of the bleeding. This is not always clear that this is the actual cause, but often we say that it is. In terms of prognosis, it's really difficult to say what they mean. They're so common that they're almost normal within early pregnancy, and a small one like this probably doesn't mean anything whatsoever. If everything else looks normal and the fetus is growing normally, then we probably wouldn't even mention it. However, sometimes you see really big ones, and those may be associated with a poor prognosis. However, it's probably not worth mentioning on a ED-based scan. It's really one for the radiologist to discuss. Alright, this is what we don't want to miss. So ectopics. Now, as an ED sonographer, you're not expected to diagnose ectopics. What you're really expected to do is to recognize an empty uterus in a woman with symptoms and that this may be an ectopic. But if you're seeing something outside the uterus that looks like a pregnancy that's clearly not within the uterus, then essentially that's the diagnosis of an ectopic pregnancy. There is a very rare circumstance in which a woman can have a pregnancy within the uterus and then a twin pregnancy outside the uterus, so one in and one out, and that's called a heterotopic pregnancy. These are very rare with naturally conceived pregnancies. However, with a very common scenario of IVF or assisted fertility treatment nowadays, these are becoming much more common. So 1 in every 2 to 300 in women that have undergone IVF, but more like 1 in 30,000 in women that haven't had fertility treatment. So really tricky, but if you're seeing what looks like a pregnancy, particularly one that lights up with colour flow outside the uterus, then that's probably what it is. So the other indirect findings would be any sort of complex extra uterine mass and anything with free fluid in the pelvis of more than a small volume would want to make you think about the possibility of an ectopic pregnancy. So a couple of traps though. This is something that looks like a mass outside the uterus and it certainly lights up with colour flow. And this is of course a corpus luteal cyst, which is a normal finding in early pregnancy. But these can be really hard to differentiate between an ectopic and a corpus luteal cyst to the casual observer, and difficult to do on transabdominal imaging. Much easier to see on transvaginal imaging, but this is beyond the scope of what you're learning. But just be aware that corpus luteal cysts are normal and they can look very much like a fiery mass outside the uterus. Another example here is the ectopic ring sign. It looks very much like a corpus luteum, and on a transabdominal scan you're not going to pick the difference. So this one needs to be followed up with a transvaginal scan if you're really thinking that ectopic is a possibility. A few more examples here of a ovary with a mass next to it, and this is the only time that we as dedicated sonographers or radiologists can actually say that this is an ectopic, is if we actually see a viable or yolk sac pregnancy outside of the uterus. It's very rare to see on transabdominal imaging, but it does happen from time to time. Now, there are another couple of types of ectopic which are becoming more common as time goes by, and the ones that you really need to think about, this one's an interstitial ectopic, which is an ectopic which is essentially implanted right at the edge of the fallopian tube, and so it's right on the edge of the uterus, and there's a very thin layer of muscle between the pregnancy and the actual wall of the uterus. So this is called an interstitial pregnancy. Pretty rare, less than a few percent of all ectopics, but it is something that you need to be aware of. It can look just like a normal pregnancy, unfortunately. A couple of other things you may want to think about, just having in the back of your mind. So this is a case of a woman who has had lots of morning sickness and has presented with bleeding and seems to have all the symptoms of pregnancy. But when you look at her uterus, which is this structure at the top here, there's nothing really that looks like a clear gestational sac. There's lots of funny looking cysts, and her ovary seems to be really expanded and enlarged and has these large cystic structures in it. And this is of course a molar pregnancy with a theca lutein cyst. So when you have a molar pregnancy, you get hyperstimulated ovaries, and they blow right up and hyperfunction and produce a lot of hormones, which produces the morning sickness as well. So be aware that this funny, grainy, grapey looking cystic appearance within the uterus can be a molar pregnancy. But once again, you don't need to diagnose this in the ED. This is one for the MIT crew, but you will find often that the beta HCG is really, really high, so maybe 300, 400,000 in a case like this. This is another example of a theca lutein cyst. This is an ovary that contains lots of large engorged cysts which seem to be squashing one another and squashing away all the normal ovarian tissue. And this is the case of a woman who's suffering from ovarian hyperstimulation syndrome, which is iatrogenic, i.e. she's had fertility treatment, and this has caused her ovaries to produce lots of hormones and become hyperstimulated and can cause lots of problems. So these women can present very unwell, dehydrated, they can have ascites, they can have pleural effusions, and they can become very dehydrated and actually go into heart failure, and are even prone to venous thromboembolic disease as well. So lots of problems can happen here. So once again, this is one where you'd be referring back to the gynecologist or the fertility specialist to get advice on what to do for this particular woman. And I'll just finish up here with a little note about our Broome Early Pregnancy Assessment Service. A lot of doctors and hospitals will have these in place. Look at the local criteria, but these are the criteria for the Broome Clinic, which you can refer to on the intranet. This is a really good place to start, particularly for those women where you're just not sure what's going on and you need to get follow-up of beta HCG levels or follow-up to look at the formal scans if you've done a scan after hours. However, I've been told by our local specialists that for the women that are in the group of the pregnancy of unknown location, so you know that the woman's pregnant, but no one's yet been able to identify an intrauterine pregnancy, and there are symptoms, they prefer to get a phone call to talk about the patient and make a plan for short-term follow-up, because sometimes the clinic may not be for another week, and that may be too far ahead for women that may potentially have an ectopic pregnancy. So please have a chat to the local gynecologist on call if you're concerned about ectopic or if you have that situation of a pregnancy of unknown location. All right, that's the end of the talk. Once again, go back to the start. Remember, full bladder. Your main goal is to identify an intrauterine pregnancy because that makes everything much easier and clearer. However, if you can't do that, the other options are that you have a miscarriage, which can be difficult, but usually we have a clear algorithm for how to treat that. And the group that we really need to watch out for are the pregnancies of unknown location, and these ones need prompt discussion with gynecology and probably a transvaginal scan in a short time frame in order to work out exactly what is going on. All right, see you later.